Hello everyone, welcome to Bright Smile Dental Clinic Pune. In this case series, we'll take you through a case of mandibular horizontal impacted third molar and its management. We'll also share some basic info on third molar impaction, especially horizontally impacted mandibular third molars, the surgical protocol for disimpaction of horizontally impacted third molars. We'll also witness some recent scientific data. So let's start. Now, the horizontally impacted is one of the most difficult type of mandibular third molar impaction. It results in bone loss, root resorption, pericornitis, or adjacent tooth damage. The common complications being pain, swelling, nerve injury, and trismus. The common prescribed surgical approach for these kind of third molars is the flap should be designed in a triangular or envelope flap manner. For the bone removal, it should be prepared or guttering should be done on buccal as well as distal bone to expose the crown. At the same time, these kind of uh, impacted teeth need crown as well as root sectioning. Recent literature on mandibular third molar disimpactions shows that there are variety of articles. Kim showed that there is minimal invasive techniques that reduce post-op morbidity. Rahman showed that platelet-rich fibrin or PRF it enhances healing after disimpaction, while Singh showed that use of piezo surgery versus rotary instrument shows less pain and swelling. The key recommendations for these kind of surgeries are first to use minimum invasive or sectioning techniques should be preferred. Second, to consider the use of PRF or collagen sponge to aid in healing. And third, to avoid excessive force to prevent nerve or bone injury. At the same time, patient recall intervals, patient instructions are also important. Let's go through this case. Patient is a 25-year-old male and complains of pain while opening of jaws. While clinical examination showed that 36, 37 were present, but 38 was not erupted, and there is adequate keratinized tissue behind. IOP or X-ray showed horizontally impacted 38, which is pressing onto 37. The case is prepared for disimpaction. The instruments are being laid out, which shows the BP handle blade, periosteal elevator, secretator, elevators, forceps, needle holder, Caesar. Anesthesia is given, both inferior and lingual nerve block anesthesia. Afterwards, clavicular incision is given on buccal gingiva of 3-6 and 3-7 both, while it is continued onto the distal surface of 3-7 and later continued in a hockey stick manner towards the external oblique ridge. After the incision, the flap is raised using a periosteal elevator starting from 3-6 to 3-7 and then progressing towards the distal side to expose the entire bone. This being a completely bony impaction, we'll have to handle the bone removal first, followed by the crown or root sectioning. So the flap is being raised. On the buccal side, once the entire tissue is raised nicely to give access to the entire part of the occlusal portion or the distal part of the impacted tooth, then we can plan for the bony reduction. So now as you can see, the bony housing is seen clearly, while at the same time there is oozing. So to control the oozing, we use this type 1 collagen sponge, comes in these kind of vial. Once you open the vial, you can take out the required quantity of the type 1 collagen sponge and keep it ready for hemostasis purpose. In this case, after the flap raise, for to control the initial oozing, we place it on the buccal surface of near the flap as well as some on the distal surface. somewhere around 3 to 5 minutes of Hemocoel application is enough to achieve primary hemostasis. This is up to 4 to 5 minutes. Once it is removed, you can see a clean dry field, and here is another picture showing the surrounding bone on top of it. Now we'll have to prepare the bone, or rather guttering of the bone on both buccal as well as distal side is done here. And again, in between, if at all there is any oozing, you can reuse the hemostatic plug or collagen sponge, that is Hemocoel, that is being kept, and you can again wait for some time for the hemostasis. Once the hemostasis is achieved, now you can proceed with the crown or root sectioning. In this case, the crown is being sectioned vertically, initially a little bit, and again the final cut is shown in the X-ray. Once that is done, the tooth is extracted. In this, the crown is removed first. As you can see, the root is still pending, and in the next step, both crown as well as the roots are removed. So both resection as well as extraction is done here. Now you see the post-operative side, hollowed out extraction wound is seen, and the flaps are still mobile. And before the closure, you can again keep this Hemocoel type 1 collagen inside the socket. Since it's a type 1 collagen, it will aid not only in hemostasis but also will aid in some angiogenesis. So you can keep it in the extraction socket and close the wound on top of it using silk sutures, that is 4-0 non-dissolvable sutures. So this is the video after the suturing is over. Suturing is complete, occlusal as well as the buccal view, and this is procedure is complete. Thank you. See you in the next video.